Hello and good afternoon. My name is Deanna Abessera and I am a part of the TrialJectory team. I will be your moderator today. And firstly, I would like to welcome all of you to our webinar, The Empowered Patient. We are very excited to have you join us for this very important conversation. Now, as we all know, the cancer landscape has changed dramatically. Patients have much more access to data and information about their cancer and also cancer treatments, whether it's via Dr. Google or information provided to them by their care team. What's important is that patients actually know what to do with this information and how to effectively communicate it to their physicians. And most importantly, how to collaborate with their physicians for the betterment of their own health. Today, we're going to be discussing all of this and much more with the goal of sharing both perspectives of the cancer treatment experience. The physician's perspective with Dr. Len Lichtenfeld, former Chief Medical Officer of the American Cancer Society, and the patient's perspective with Shona Furlong, a breast cancer survivor and TrialJectory patient champion. We'll be asking a series of questions, giving each panel member time to respond and to discuss these topics. There will also be time at the end for open questions from our audience members. And now it's time to welcome and introduce our panelists. Shona, please tell us a little bit about yourself and your cancer journey.
Sure. Thank you so much. I really appreciate being here today. Dr. Len, it's so nice to have your time today. I know you're a very busy man. So what a treat for cancer patients to be able to tune into something like this today. So I have to say, I was telling the group earlier, I met a number of individuals from TrialJectory yesterday, and I was just so very impressed about the compassion, the passion for their support of cancer patients and the cancer journey. And so it was just so authentic and lovely to be asked here. So I'm really quite honored. My name is Shona Furlong. I should start by saying I kind of have sat on both sides of the fence. I am a registered nurse by trade, but unfortunately also a cancer survivor. Very quickly, I'll just give you an idea of how I got here. In 2018, I went on a family vacation to see my parents in Phoenix. And when I got there, I went to get changed into the lovely weather, and I put on a sundress, and unfortunately I found a lump. I gave it the evening, but didn't feel very good about it. Went for a walk the next day. I did call my family physician, who said, geez, you're young, you're healthy. It just doesn't seem very likely. Give it a month. We'll come back. We'll drain the cyst. Go on to enjoy your vacation. So again, I gave it a few hours, and it just didn't sit right with me. My instincts, kind of kicked in. And, I called. I was fortunate enough to have a family physician that I knew that was practicing in Phoenix, and just asked if he would mind to refer me for a mammogram. I went in at 8 o'clock the next morning, and by 4 p.m., I actually had a diagnosis. I'd had a PET scan. I'd had several MRIs. I had all my biopsies done, and I was diagnosed stage 3. And I also had a 2-centimeter lump in my right axilla as well. So advanced cancer for sure. So I really, I left there feeling very strange. Very fortunate, given that I am from Canada. I'm actually sitting in Thunder Bay, Ontario today. Knowing and having been a part of 2 different systems, I knew that things would come quicker through the US system. And so I just felt very fortunate, but a little dazed and confused about, so now what? I'm now a 45-year-old mother of 1 with advanced breast cancer. I went on, and maybe we'll talk about it as time goes on here, but I did go on to bridge my care between the US and Canada. And I really learned what it meant to be an activated and empowered patient. And I have to say, I think I'm sitting here today because of that. I have to say that I was very, very fortunate to have different people and tools, one of which actually we're going to talk about today, and that's TrialJectory. The people and the tools that I kind of assembled around me and were willing to become part of my care team, who helped me to put together a treatment plan that spanned, the regular plan of chemotherapy, surgery, radiation. And then I went on to be a part of an oral chemotherapy trial, which very happy to say that now is part of standard of care. That's kind of my journey and how I got here today. And I'm just, very pleased to talk about what it's meant to me to learn to be activated, to learn to be empowered, and then really to reach out and use the tools and the services from companies like TrialJectory and others to help you consume, the amount of information you need to put together the complex treatment plan that is required to restore your health is unbelievably overwhelming for both clinicians and patients. And so it's paramount that you use tools like artificial intelligence and search engines and things like that to help collate and make the information consumable and usable so that you can incorporate it into an effective treatment plan. Does that help? That's kind of who I am.
Absolutely. That was very, very poignant and powerful. And thank you for sharing and being so candid. Yes, it's absolutely important to have your voice be instrumental in your own cancer care. Thank you again. And Dr. Lynn, can you please take a moment to introduce yourself as well?
Thank you. My name is Len Lichtenfeld, formerly Deputy and Interim Chief Medical Officer for the American Cancer Society. Left the society about 1.5 years ago, currently the Chief Medical Officer for a company called Jasper Health, but also advised several other companies, including TrialJectory. I've been involved with TrialJectory for the past 1.5 years, I guess it is, that I first met Svea Bader, the CEO. But I will share the reason. I try to think of what's the theme that I've been active in medical organizations and I was going to say politics, not politics, legislation, regulation, payment, all sorts of things around healthcare in general, not just cancer care, but more specifically cancer care for my entire professional career. And my theme and my concern today as we're having this conversation, and what's really been underlying many of the things that I'm doing, is how to help transition from the care we used to receive to the care we can receive to the care we will receive sometime in the future. And I do firmly believe that patients, caregivers, families, your circle the circle around you is going to become critically important. We're undergoing really significant systemic changes way beyond the discussion we're having here today. But the reality is that the care that we're going to receive is not will be a different system than what we're used to, especially folks like myself who are older. And of course, as we're aware, Shona, you made a very clear point. Frankly, I've got all these notes here about what you said because you touched on so many things. But cancer is a disease of older folks generally, and who are not quite as sophisticated, shall we say, or not much as engaging as our younger population. People like Shona, who obviously had a very significant role in helping to understand her care and participating in making critical decisions. And I personally think that is very important to ensure the best outcome.
Absolutely. Absolutely. So well said. Okay, well, wonderful. And again, thank you both so much for being here. I guess we can get right into it. Dr. Lynn, we got one question for you. In your opinion, how would you define an activated or an empowered cancer patient? What does that look like to you?
I don't have to define it. You just heard it. Okay. And like I said, I've got all the notes. This has made my task a lot simpler, to tell you the truth. I mean, you've already heard. I think one of it's an unfortunate and difficult circumstance. No mistaking that. But I'm so grateful that Shona has shared her story in such a direct and effective way. When you start talking about activator empowered patients, I mean, the reality is the very first comment that I made here on my note list, which I'll be happy to share with you if you want to see it, was awareness. And the difference that makes, particularly in breast cancer and many cancers, but the awareness that something was not right and taking prompt action. I come from an era where people would notice things and they would ignore them, and still do. I mean, a lot of folks still do. So awareness is important, but also engaging, asking questions, getting information, accessing the tools that are available. And once again, we heard a whole series of tools. Unfortunately, most people don't get the care that Shona got. I mean, that what you experienced that day is much more the exception than the rule of people really taking, not just yourself, but the system taking charge. So you have to be aware of what to expect. You have to be aware of what the next steps are. You have to be able to be, you have to be, shall we say, I hate to say literate, but you have to go and get the information, whether it's, there are a number of excellent websites out there. American Cancer Society, cancer.org clearly is one that's well respected, has lots of information. But when you get to clinical trials, we've talked about TrialJectory. But gathering information, being comfortable with your care team, asking questions, and making sure you know what the steps are. The good news is there are many folks out there who are able to do that. The unfortunate news is that there are a lot of folks who can't. And that gets into all sorts of other issues. I mean, I've been around recently around some people who've been newly diagnosed with cancer, and quite frankly, the information's going like this. I mean, you sit down and say, tell me what's going on, and they don't know. But we have to, to be part of the process is a good thing. Asking questions is a good thing. Knowing the next steps is a good thing, and knowing what your options are, particularly as we're talking today about clinical trials and next treatment steps, is also a good thing. We've come a long way in cancer research and cancer care, and we're at a time when it's been absolutely incredible. I'm not somebody who's an apologist for I don't run around saying everything's great. I don't do that in my career, but right now, at this point, I have to say that there's been so much change, so many advances. We just have to make sure people get access to it, and that they're also prepared to take advantage of the next advances that are being developed as we speak.
Right. And just to piggyback off of what you just shared, I think being empowered also perhaps means being educated about what options are out there. So, and finding your voice along the way. Shona, why is it important, in your opinion, for cancer patients to be more engaged in their own treatment? I know you touched a little bit upon this earlier, but maybe you have a few things to expand on.
Sure. I kind of have the benefit of seeing it from both sides. I don't think I mentioned earlier, but I think you and I discussed, so my sister's a long-time oncology nurse, which at times seemed so strange when I was diagnosed, because I thought, oh boy, I should have known better. So I really do have an understanding of both sides of the table. And, we have this discussion often, her and I. It's just so important that you consider yourself a part of your care team. I know for myself, when I was first diagnosed, I felt very, even being a clinician myself, and I did have an A team. My mother's a nurse, my sister's a nurse. We're involved in healthcare. We had connections, but I did feel very helpless initially, and I just kind of felt like the patient laying in the bed, constantly. To be honest with you, it seemed like all I did was put on my top and take off my top, to be candid, I guess. I quickly kind of made a transition because I needed to stop feeling so helpless, because helplessness makes you feel hopeless. And a hopeless patient, I guess from my nursing days, I would tell you is one that gets ill very quickly. So we need to restore people's hope. And a patient needs to restore their hope, because when they believe they can restore their health or get better or have a better quality of life, they often do. And so I believe that being, educated, activated, and when you transition to being a part of your care team instead of the patient laying in the bed waiting for somebody to give you your next appointment or your next treatment or your next diagnosis, then you come to the table and you start you start feeling like, hey, I can do something about this. And Dr. Len is so very right. We are in this very fortunate time where, the medical advances are fast and furious, and there are way more options out there than the standard of care. And so we should not accept the standard of care. I know that I certainly transitioned to deciding I wasn't somebody that was going to just take what either my insurance company said I was eligible for or what the person in the office before me was given. I wanted something that was going to be tailored to my cancer, because we do know, unfortunately, we know that cancer is not the same. I mean, I wish it was a pill and we could fix it all, or a Band-Aid, but it isn't. My cancer is not like your cancer, is not like somebody else's. And so, the complexity of it is that it requires such a tailored approach. So the other thing that I think why you have to sit at the decision-making table is because you have instinct. You have that, you're the only one that knows your own body. You're the only one that knows how aggressive you're willing to be. And so you have to come to the table and say, okay, so I've made myself aware. I know I know myself. I know what I want to do. I know where I want to go. And I want to sit at the table with you as a colleague in this, instead of the patient laying in the bed waiting for you to deliver the next treatment that may or may not be aggressive or that may or may not be cutting edge. So that would be what I think.
You just gave me a perfect transition into the next question, which I find fascinating. And Dr. Lynn, this one is really, I would say, more for you in the beginning. What should the patient do when the relationship between the patient and the physician is maybe breaking down and not working? And what advice do you have for patients who are concerned about offending the physician or worried about asking for a second opinion because it might affect their treatment outcomes?
So I'm going to blend something that Shona said, and there's so much. I think we should just have Shona because she is terrific, and all the points, and I so appreciate your experience. I don't appreciate the need for your experience, but your clinical experience and your family experience and your ability to share that, because there's so many elements of that. Let me tell you, and you said, what about when the clinician goes bad? But let me talk, I said, blend a little bit with what Shona said. There's a fundamental assumption, and it usually, fortunately, is a reasonable assumption, because I don't want to be misquoted or misunderstood when I say this, but it's still very important. There's a fundamental assumption that when the care you're being advised is appropriate care. There are a lot of influences that get people to making a particular treatment decision, and Shona mentioned insurance companies. That's an example. An insurance company may say, well, there's no evidence, when in fact, highly regarded clinicians believe there's plenty of evidence that a particular treatment, or they may say, well, we want you to start this treatment first as opposed to that treatment. So there's a lot of that goes on, but you really need to know what the next steps are. And getting back to real world experience, some recent events, people did not get the right next step. And as it turned out, an incredibly, not a common story, it turned out that getting the next step, no matter if it offended somebody or didn't, made a significant difference in the treatment and hopefully in the outcome. They can't promise the outcome, but at least put them on the right track that they never would have been on had they not had the opportunity to get some other advice about it. the biggest problem, I've talked to how many thousands of patients over the course of my career. It is so terrific when you have a care team that cares about you and knows you, and you feel that confidence. In fact, I'm going to say something else. I'd rather have a high quality care team around me than the world's expert in the disease, because the high quality care team, and instinct does play a role in that. Now, you can also have instinct that says, well, this doctor's wonderful, but they're not so, or this clinician, it's a team, they may not be so good. And Shona, you may have had that experience yourself, and others, who've been in the medical profession. So instinct is great, but not always. But at least if you know somebody cares about you, you're onto a first step. If you have a bad relationship with a high quality expert, you really need to think about, is this the person I want to put my life in their hands? Because that person may not be there when you really need them. Mm-hmm. And when you have cancer, and I'm going to give a big shout out. You mentioned about your sister, Shona, being an oncology nurse. The oncology nurses are the angels. You may, everybody probably on the call is aware that President Biden's son passed from brain cancer, and glioblastoma, I believe it was, and he gave the Cancer Moonshot talk a number of years ago, about 6 years ago, and he did it across the country. And his comment was, he started by saying to all of you doctors out there, I hope I don't offend you, but to all those nurses out there, you're angels in heaven, because they are a huge support. But if you're not comfortable, first off, there's no law that says you can't have a second opinion. And sometimes you're very comfortable with the care you're getting. You've researched it, it sounds appropriate, whatever. Okay. Sometimes you may have to meet the family. The family says, well, why don't you go second opinion? And they say, okay, just to keep everybody happy, I'll go. And sometimes you really need to get a second opinion because you're not comfortable with the care you're getting. You sense that something that you're not getting answers. You don't understand what's going on. The treatments don't make any sense. You've heard about other treatments. Then you need to get a second opinion. Getting second opinions are not easy, by the way. We talk about them. I live in Atlanta, right? Or if you're in Phoenix, Arizona, or you're up in Ontario, in Toronto, for example, you can get second opinions. But some people, it's really difficult, more difficult. Virtual opinions are available. But at the end of the day, this is your life. And you have to be comfortable, and your family has to be comfortable. I do see a lot of what I call the other side of the coin, where people are comfortable, and maybe they shouldn't be as comfortable, where second opinion, at least establishing a relationship. A drug may be a new drug. The doctor who's a mystery has never used it before. That's not bad or wrong, but maybe you need a collaborating expert where you can turn to in your time of need. Better to establish that relationship and make sure that what needs to be done is being done early. It's not easy. I mean, it's not simple to say to a doctor or say to a clinician, say, I don't like you. I mean, don't say I don't like you, but say, I really want to get another opinion. You shouldn't be afraid to say it. Most physicians, oncologists understand it and actually expect it. And if a doctor resists you by saying you can't get a second opinion, blah, blah, blah. Sometimes the situation is very acute leukemia being one example. But most of the time, you can take the time to get, particularly, let's talk about breast cancer, particularly in breast cancer, when this management decisions, getting that second opinion and research that's been done in the past has shown a substantial number of people who end up with a different the nuances in the diagnosis or nuances in the treatment that make a difference in their outcome. So, you've got, again, coming back, you've got to be your advocate and you got to be willing to ask. And I wish in smaller communities, I wish more people would take on that quest, shall we say. Right. Because when you live in a small town, sometimes it's even more difficult because it's everybody is so interwoven with each other.
Right. I think our brains, we're trained to trust the experts, and
Well,
a lot of times we don't trust our own instincts. And I'm wondering, Shona, in your own experience, because you are from the medical field as well, how did your own doctors respond to you coming in with queries and questions and perhaps, trials? What was their reaction?
Yeah, I think so. A couple of things, and Dr. Len is so right. You said all of that so eloquently, so I don't want to repeat anything. So I'll just speak from my personal experience, and that's that. A couple of things seem to help me, and I have encountered both. I've encountered physicians who took it on as, gee, what can I learn from somebody that you've found, or some treatment that you've found? That's been fantastic. And I've had others who maybe have been offended that I went looking for another answer. But one of the things that did seem to help is if I was transparent right off the hop. So if before we got too far down the, you're my doctor, I'm your patient. If I said, look, if I told them I tend to blend my care, I am an aware and an aggressive patient, and said to them, how do you feel about that? It gave them a chance to say, that was something that was care they wanted to be a part of or didn't. And so, I found that as I went along, it was very helpful if right off the hop, I kind of said, this is the kind of patient I am, and this is what I'm expecting. And, you can expect me to bring novel ideas to the table, and, that I may be including other people, other institutions. I have bridged my care in the past between two countries, with multiple different providers. I used a company and an individual, I used Vicure and Foundation One for my precision medicine. So, I kind of brought that to the table right off the hop. And that seemed to give clinicians a chance to, either accept or maybe tell me that I might be a more appropriate patient for someone else.
Mm-hmm. Okay, gotcha. So
Yeah.
I think that's also important, and to really kind of set the playing field right out of the gate, right? So that you can kind of set expectations with your oncologist. Dr. Lynn, in your
can I just say a comment? I'm going to. Okay. So first of all, I want to make a point that I think is important we can't overlook. Sometimes people don't want to be treated aggressively. They have come to that decision. They may be at a point in their treatment. And I think that needs to be respected as well, that not everyone is going to go, so there's a spectrum here. And I think it's appropriate that we at least, take cognizance of that. But, there's a real problem, and particularly with older folks, where I talked to one patient, actually the sister, unfortunately the patient had passed, where it was a case of cancer, cancer of the esophagus, older woman, and the sisters came to me and said, I wish they would have asked what we wanted, as opposed to doing what they wanted. And that maybe the decisions would have been different. And now there's an increasing recognition that patients, there've always been wonderful doctors out there, nurses and other clinicians who have always asked, what's right for you? What do you want? Where are you most comfortable? There's a lot more recognition of what's called patient-reported outcomes. That is, what are the side effects? How do you feel today? How do you feel tomorrow? How did you feel yesterday? Is there a change? Can we address that change? So there's an increasing recognition, but unfortunately, it's not enough. And you should have, you and your care team should have a clear understanding of what, and Shona articulated that very well. There may be people out there who are not comfortable with a patient who asks a lot of questions, may not be comfortable. I'm not a big fan of diet therapy. I'm going to be honest. There are people out there since the beginning of my career who were telling me this diet works, that diet works. Show me the evidence and I'm happy. But that may be something that we need to have that discussion. I'm not going to be you bring a nutritionist in. I may not be the person for you. Maybe not. Maybe yes, maybe no. Right? Let's have a conversation. Set your goals and set your expectations, and make sure that the care team and if it's the physician, the oncologist, clearly understands what you want out of your care, because ultimately, once again, this is your life. And what you want may be different than what the clinician wants. With that, and that, no matter what the topic is, has been shown time and again, the clinicians have bias, and they tend to transfer that bias onto your decisions. But that's a larger question than just in cancer care. That's something that's been seen in research studies have been done for the past several years.
Right, right. So important. Dr. Lynn, in your experience, and I think we've discussed this already to some degree, do you find that in today's landscape, physicians are open to being more collaborative about cancer care with their patients?
With their patients and with other clinicians, because cancer care is developing rapidly into a team sport. And that's what I will tell. Well, that's not a sport. I say these things, and you good golly, and somebody may say, how can you talk like that? But
no,
but
it feels like a sport.
Yeah, well,
that's great.
It takes. I've been.
It's a team.
I am a patient. I've been a patient in a life-threatening situation. Had to be dealing with infection after a joint replacement. I was in a small town with excellent doctors who I knew. They were my friends and who cared about me, and I cared about them. But when things were getting out of hand, I said, and they all knew me. That was a secret. I said, I'm going to start taking over the reins of this team, and that was okay because we were all together, and I had people I knew, and it made a difference in that care. So that happens to all of us. I think, I sat in a lecture. It was not so much a lecture; it was a luncheon talk from somebody who is the head of the Institute of Medicine, major academic government oversight program, one of them in the United States. And this is, I got to tell you, 25 years ago. And this person, maybe even longer, this person stood there on that podium and they said, medical care is changing, and you have to be prepared as a physician. And he's talking to a group of internal medicine doctors, of being a physician, of helping the patient interpret the information that they're going to bring to you. That the model of you are the authority and not to be questioned is going to go away. That was 25 years or more ago. That was a long time, and we're still having those conversations. So you may find some physicians who are willing and some physicians who are not. But here's the underlying thing that I talked about earlier. We're in a world of transition right now. I don't know whether that transition is going to happen next week, next year, or 10 years from now. These things tend to take a long time. But a lot of healthcare is going to have to be collaborative healthcare, because our system isn't going to allow everyone. We as individuals, for better or worse, and some people are concerned about access and about equality of care. For better or worse, we're going to be more and more responsible making sure things get done, because we're not going to have a system of care that follows us from beginning to end. We're going to have pieces of care that are sort of put together. And then that means you have to know more about what's going on, because you may be here today, but you're going to be there tomorrow, and over there doesn't know a darn thing about what's happening to you over here. Right. So there's going to have to be a lot more collaborative practice. A situation in my own family where someone had sustained a traumatic injury, was transferred to a teaching hospital 2.5 hours away. We never got a phone call. We, as physicians who were family members, nor the person's physician, ever got a phone call from anybody asking about the person who had been injured. Nobody ever called. They put them in a room, did their thing. I have no idea how they had any clue about anything about her past history or medications. That is not acceptable. So we're going to have collaboration. We're going to have systems. We're going to have people who understand their situation and their illness. That's critically important in cancer care, because cancer patients do end up in different places and have to be able to share the information or have the information shared for them.
Absolutely. I mean, collaboration seems to be the key here. Well, we are at the point now where I would like to thank you both for giving such candid points of view on what it really means to be an empowered patient during what essentially is the fight of your life, and how truly important that really is. And we will now open it up to questions from our audience. Let's see what we have here. Okay. Let's see. Dr. Lynn, how do you feel as a physician when a patient comes prepared with treatment options and information about their cancer? And I think we discussed this a little bit, but are there anything else you would like to add when a patient comes into your office who's prepared? The conversation goes in a much different way, I suppose, than if they came and you're just starting out with zero information on the receiving end.
No, well, I'll try to be brief. Okay, I can talk forever, and I know that. I apologize.
No worries.
As a physician, I sat here the other day, and well, I shouldn't say this, but I have to be careful. When a patient comes to you as a physician and they have an element of knowledge, and if they don't have an element of knowledge, that's okay, because that's what your role is. Your role is there to help them, whatever. But some of the most rewarding encounters are when somebody comes in with information and you can share information back and forth and help guide them to a better place for themselves. I don't actively practice, but I do talk to people around the country. Just as a courtesy, I did it with the Cancer Society, and I do it now. Just listening to their situation. And I have the luxury a lot of people don't have, a lot of physicians don't have. That's the luxury of time. I don't know all the answers about the care these days. I don't know any oncologist anymore who does. I mean, you go down into the treatment of any disease and you get very granular very quickly, and you really need to have specialty knowledge. I mean, to be the general oncologist is still possible, but it's getting more difficult. If I have someone who's able to have a conversation, I think it's and that I feel that we are working together and that they are trying to determine what their options are. Sometimes, and that's not always an easy conversation. A conversation with somebody about the treatment of leukemia, for example, recently, talking about two different treatment regimens, one of which was a clinical trial, by the way, and trying to help that person. I can't make the decision for them, but help them get to a place where they made the decision, and it turned out, fortunately, to be a good decision. There's nothing more rewarding than that. Now, if you have somebody who comes in and says, I've got a stack of papers and I have 500 different things that I brought together, I want you to help me understand it. No, I can't do that. I don't know many physicians who can. There's still an element for most physicians who are engaged in cancer care to try at least have some sense of where things need to go. And if the quest for information takes you so far off your comfort level, then the relationship becomes problematic. So I would not be perfect for everyone. There may be other doctors who are more able to do that than I. But having an informed patient, an engaged patient, someone who has a sense of what the options are, helping to make a decision. Sometimes those decisions are difficult. That's human relationship. And that's right. To help work together. You get very close to the people you treat, and you want to make sure that all the things we've talked about are included. All things that Shona has mentioned have been included.
Right. Thank you. We have a very interesting question, and this is, I suppose, for both of you. Do you see the future of cancer treatment more rooted or dependent upon technology than it is now? Do you think that that will improve patient outcomes?
Shona, why don't you start about from your perspective, and then I'll weigh in.
Okay, great. Yeah, it's funny because one of the things I'd written down when I was just considering some of the things that I thought were important to pass along is I think technology is our friend. And I want to be very careful because I do think it is a bit of a generational issue. And so that's where I think it is important, again, to kind of assemble your A team. If you are an older person or perhaps where technology is difficult for you, you have to kind of have that A team around you that can help you use it. I think it's critical. I think it's pivotal to making sure that you are accessing the most novel treatments that are available. And I know, so I kind of told the TrialJectory team, one of the reasons I got involved was, and I'll be very quick, but I can remember there was a day I was laying at my cottage, bald as I could be, very, very, very ill. I was kind of at the height of my chemo. I'd really accumulated quite a bit and was very ill. One of the first days I actually struggled to walk. And so I had a lot of time on my hands, and I had some push messaging coming through because I'd been Googling different chemo regimens, and TrialJectory came up for me, and I went in, and it really did become my friend, because what it did was it made the information consumable and useful to me, because as you said, Dr. Lynn, what you can't do, and when you're very ill, and when you need the information the most, both the patient nor the clinician have the time to sort through, 500 journal studies on what you should do next. But the artificial intelligence or the search engines that are embedded in things like TrialJectory, they allow us to put in some very simple information, and it was something that I could actually do that day. I was quite ill, and yet I was able to put in my information, and then information started to come back to me in a way that was tailored, a way that I could consume it and understand it. And that was kind of the beginnings for me of saying, okay, so where else could I go? What else is new out there? And what are my alternatives to what's being suggested to me? So I guess the answer for me is, having been through it, my personal experience is that technology is 100% our friend. It can consume and interpret information at a rate that can actually keep up with medicine. And that's a good thing. That's my thoughts.
Well put.
Let me extend that just a little bit. I think there are different types of technology, and I think there's what I would call enabling technology. And what Shona is referring to is the technology that's available to provide information. I come from an era where there was no internet, right? I hate to say it, but heck, there was no even computers or word processors, but that's another story. I mean, the good news is that I love technology, and I'm good at using it. But for patients and families and friends, technology helps to layer that information source. Laugh about Dr. Google, but Dr. Google can be a help. American Cancer Society website, I mentioned other websites, cancer.gov, are useful sources of information. So that's one piece. The other piece is technology can deliver service to you in a way that you might not otherwise have access. TrialJectory, being a clinical trial search engine, allows you as a patient, or a physician for that matter, to get updated information on available clinical trials. And you can get that information no matter where you are in the country. And I suspect, fair to say, wherever you are in the world. We couldn't do that before. We couldn't even do that recently. People have been trying to do this, and so there's a democratization of access. People need financial counseling. People need emotional counseling. People, I mean, not cancer related, but I even saw an ad for weight control, a new medicine that's available. The technology can bring care and care to you. And then there's technology of, what are we doing in terms of, you mentioned foundation medicine, and I don't have a formal relationship with foundation. I'm an advisor at a company called Garden. But the ability to get into the blood sample and pull out the needle in the haystack that has that cell that might tell, or those cells that might give you information about the right treatment. That's technology about practice, or technology that reads a mammogram better, or all sorts of technologies. When we get into the treatment technologies and some of these other things, that's where we get a little concerned about what we call the digital divide. And some people are able to take advantage of that, and some people, unfortunately, are not. So that's a larger question for another day. But all of these areas, technology has made a huge difference. And I just wish we could get technology that could help guide patients through the care process and make sure they don't get lost, make sure they get the right care, make sure that all the baloney that goes around it with pre-authorizations and all that. I wish we'd have technology that really worked to make the process simpler, because we are all drowning every day in technology. We need to make technology work for us. And TrialJectory is an example, as Shona has well stated, of a technology that works for people. And that's where we need to go.
Wonderful. Thank you so much. We had another question come up from an audience member. As a doctor, at what point do you view patient research as annoying or inappropriate? And should patients actually be researching everything their doctor tells them when they go home?
Wow. Well, if you try to do that, then you'll be overwhelmed. Shona's made an excellent point on several occasions. When you're sick, you're sick. I mean, and you're not going to be able to do a lot of research. And they're really, and one of the comments that I do make to folks in those phone calls I talked about is that there comes a time when you have to put trust in your care team. When you're comfortable that they're acting in your best interest, that you're communicating together, that they're knowledgeable, you got to put trust in the team. That doesn't mean you don't read, you don't look, you don't inquire, you don't. Social media we were talking about before. You have groups of folks with particular diseases who get together and may share information. But if you come in every visit with 200 articles, I mean, you're not going to make a connection because a lot of that, the hardest part, and this is, I was talking to a physician friend of mine, not an oncologist, an internal medicine physician, and said, one of the, and it happens to be an excellent doc, and the kind of thing that I wish more of us would be like. One of the skills of being a physician and being a clinician with experience is that you do have the capacity of saying what's important and what's not. Now, you can't be arbitrary about it. You have to be open. And I promise you, there are things that I see that I say, wow, and I go down and I follow it through. But there is some value to that experience. If you're not trusting in that care team, then that raises a serious question. They won't be able to answer every single question you have. I mean, I had somebody the other day, and I don't want to get into politics, about COVID vaccines. And there was an article in a magazine someplace that talked about mRNA inserting DNA into liver cells. And this is a concern to them. And I went back and read the study, and the study made the comment about how the SARS virus itself gets into liver cells. And this is a vaccine that, again, people may not agree, but it's been given to millions and millions of people with some side effects, yes, but incredible value of saving lives. That's what's so critically important. And it saved a life in my own family. So I feel sort of passionate. I came back and I said, this is a lab study in a cell here. This is not something that's going to be pertinent for the question you're asking. And so you have to at some point have the trust that somebody has knowledge. You may not agree with me, but that is what makes the difference today, isn't it? We're having a conversation about not agreeing on everything, but if you don't agree on most things, then you have to ask if this is the right place for me to be.
Right. That's a very good point. Shona, we have a question that is very interesting and something I actually thought to ask you myself. As a patient, Do you feel that it was harder or easier for you to navigate cancer having a medical background?
Oh, great question. You're not the only one that's asked me that before. I think it was great in some ways because it afforded me, and I would never, ever, ever go so far as to say that I wasn't a little bit privileged in terms of having some idea of how to navigate the system. And at times, it makes me want to really lean into advocacy, and I try to extend that wherever I can, because we really are privileged when we're on the inside looking out, because sometimes we can make less calls to make a connection. We can, access diagnostics, things like that. And there is, I don't want to call it queue jumping, because I think I'm very careful of that, but at least sometimes I know a shorter path to getting to an answer. Or perhaps I know a person that I can access to get information that is valuable to me. So that part's wonderful. On the fear side of things, sometimes I used to say to my husband, it would be blissful sometimes if I didn't understand completely the gravity of my diagnosis, or of some of the things, the survivability, things like that. Sometimes it would be nice just to close the book on it. I know my husband sometimes would say, "Oh, for goodness sakes, let's just close our eyes and know that everything's going to be okay." And I tend to sometimes go down a rabbit hole because I know better. But it's also a blessing because, I think I so appreciate the work that you at TrialJectory are doing, and all of our clinicians, and I have real empathy for them as well. They really are out there every day doing absolutely their best to restore our health as cancer patients. And I've had the ability to see it on both sides, and that's wonderful. And all I can do now is go out and support it.
Right. Wonderful, frightening all at once.
Definitely at times it increases the fear factor. So that part I didn't like, but there's a privilege as well.
Of course, of course. This question is for both of you. And is the general consensus that clinical trials are the best option generally when they're available for cancer patients? And should every patient be pursuing them? Dr. Lynn, would you like to start?
I think clinical trials are appropriate for some patients in some circumstances. I wouldn't say for every patient in every circumstance. There are, a lot of the treatment, and Shona, I suspect you may or may not be aware of this. I mean, a lot of the treatments that Shona's received, without going into a lot of detail, are all based on clinical trials that occurred at some point in time. But the clinical trials that were well done have in fact, nothing is ever absolutely settled, but they certainly are pretty settled pieces of information. Let's go back, and I'm going to talk a little bit about breast cancer. When I started practice, the typical breast cancer patient had modified radical mastectomies. Modified radical mastectomy meant taking off part of the chest wall, taking off the entire breast, dissecting out the lymph nodes, and leaving a woman, with significant disfigurement for life. That's where breast cancer treatment was. Today, depending on the tumor and a lot of other factors, you may be a candidate for a lumpectomy. You may have lymph nodes involved. You may not need intensive. I mean, there are tests that help tell whether you need intensive therapy or not. We know that a number of women, particularly postmenopausal women, don't need chemotherapy after breast cancer. We have drugs like Herceptin and trastuzumab, and all the follow-on drugs. All those came to be because of clinical trials and people asking questions. So they're probably, I'm going to be pretty bold by saying this, if I went back through Shona's care, including the mammogram she got, including the MRI she got, including the biopsy she got, and the technique for the biopsy, every element of that care at some point was part of a clinical trial. Do we have to recreate that clinical trial every day? for every patient? No. But when we get to those decision points where we don't have information, where we don't know what the best thing is to do, and there's a reputable trial available, I think it's clearly to everyone's advantage. And there are so many things that hang around out there, such as, well, if I go into clinical trial, they're not going to give me any treatment. No, that's not true. There were times, believe it or not, in lung cancer, well, we did have to compare no treatment to treatment because the treatment wasn't doing so good. So we asked that question and we went past it. We answered the question. So yeah, I mean, clinical trials are valuable at the right point, and you should be open to that option. Is the clinical trial the necessary thing right out of the gate? Maybe not, but sometimes maybe yes. And let me just, one final thing. I read an article the other day about the FDA approving chemotherapy and immunotherapy for the treatment of primary lung cancer, localized primary lung cancer, versus surgery. And guess what? For a quarter of those patients, the chemotherapy turned out to be a much better option than the surgery. So not perfect, but that's the kind of advances we need to make. So there's somebody who walks in, has lung cancer. Yeah, that clinical trial of primary localized lung cancer. Yeah, chemotherapy and immunotherapy is an option, and that was discovered because of a clinical trial. Same thing in breast cancer. Large tumors shrink and sometimes go away completely because of new treatments. And I'll tell you something else, one final point. Talking about breast cancer, Herceptin, trastuzumab, back about 2004, I was in an audience of 10,000 doctors who stood up and applauded because there was a clinical trial, 2 clinical trials, I believe it was, were reported that showed that Herceptin saved lives of young women with advanced breast cancer. Today, we take it for granted. Today, we're trying to improve on that, still doing clinical trials. And every trial is another step to help us say, yes, this is better, no, it's not. So yes, clinical trials make a difference, but when used at the appropriate time in the appropriate circumstance.
Right. That's great to hear. Shona, do you have anything you'd like to add to that?
Not really, just he couldn't be more, more that, many of us today are here and celebrating anniversaries because people have participated in clinical trials. So making it accessible is just, it's so important.
Agree with you wholeheartedly. We have time for one final question, and this is a great one. And I'll let either one of you and or both answer. Do you feel caregivers are a critical part of the patient's cancer journey?
Shona, you go first, okay?
Answers they are. If you're fortunate enough, and for people that don't, we need to identify those people and get them a circle of care as quickly as possible because cancer is, it can, actually, it was funny because I used to say when I just knew I had cancer, it was no big deal. It was when I started treatment that I got really sick. So, you unfortunately many times do end up in the treatment process, and thank goodness for it. But to get from A to B, to get through it, you really need that A team around you. It's absolutely critical. So, one of the first things I tell people, because I do get phone calls to say, gee, I was just diagnosed. What did you do? You start right away, finding that who's your A team, going to help you through the day-to-day, who's going to help you make decisions, who's going to be your emotional support team, who's going to come to your physician appointments and help you make those critical decisions, so many things. It's unbelievably important, and we should seek to be a part of people's care teams, whenever they need us.
So if I can expand on that, obviously 100% correct and on target. Caregivers are so vitally important. They're the support team. They're the transport team. They're the people who hold your hand when you don't feel like you can make it another day. They're the people who sit and listen after somebody says you have cancer. They're the ones who can sit and listen because you can't to what the clinicians are telling you to do. And caregivers, and you mentioned the word about circle of engagement. Caregivers go way beyond just the person who may be sitting sitting with you in your house. They can be your friends, your neighbors. They can be your church, your synagogue, your mosque. They can be the people who come. I mentioned earlier, I get a little emotional about this. I went through a period of time, not anything compared to what Shona went through, but it was a pretty serious situation that I referred to earlier. I'll never forget when somebody knocked on the door Sunday night with some food for us and said, "Thinking of you." You don't forget those moments. You don't forget the moments when you're taking a trip and people can see that you're sick and somebody says, "What can I do to help you?" And our prayers are with you. We have lost some of that in all the things that happened in the last couple of years. We think we've lost some of our humanity. I suspect many of us today still believe that humanity exists, and caregivers are the greatest examples to make our lives easier in our times of need. So open the door and let them in.
Wow. You have both touched me deeply. You've been so generous and candid with all of your stories and information. And I could talk to you all day, but unfortunately, this does bring us to the end of our webinar. And Shona and Dr. Lynn, thank you both so much for this informative, insightful, powerful discussion. And thank you all out there for taking the time to join us today to learn more about what it means to be an empowered patient. We will be sending a follow-up email to everyone with a recording of this event and encourage anyone with any questions to reach out to us at the following email: marketing@trialjectory.com. That's marketing@trialjectory.com. And on behalf of all of us here at TrialJectory, we are wishing you good, sustaining health and a wonderful rest of your day. Take care.
Thank you.
Thank you.
Oh my-